on the ground. He is there for whatever project we need. We think of this person. I'm not exaggerating. This man is a senior lecturer and consultant community physician. He's working at the Department of Community and Family Medicine, Faculty of Medicine, Jaffna, and he's the chairman of the CANE Jaffna. This is none other than the man who doesn't sleep, the man who is always working, Dr. Rajendra Surendra Kumar, and he's going to talk about the palliative care initiative in the northern Sri Lanka. Suren, you have 10 minutes to go.
Thank you, Dr. Varun. This more exaggerated introduction about me, but then I hope, sorry, this presentation is all can now that is available, all of you can see. What I want to cover actually, most of the introduction part with these Madhuragan's great insight what is going on about this palliative care. After that, then Jonathan gave a very good introduction, what is palliative care and why do. So with that, I want to tell exactly that within 10 minutes time, then what sort of situation that we are really in Jaffna, the northern province, and also then the initiatives. So there are so many initiatives, and then we are like compared to other part of the country, and this northern part is doing better than thing, but then but there are a lot of challenges. So we need a lot of support, and then there are way forwards. So we know that most of us, we don't like to talk about death. So that, but it is imminent. We can't avoid that. But that more, if we don't talk about that, then we can't plan it. So most of the time in the even medical fraternity, that most of the physicians, they struggle and they don't accept the death of their patient. But anyhow, that people are going to die. So, but that the important is that to ensure the dignified death of the person as a human. So then the people, some people die suddenly, some people deteriorate and go, and as Jonathan also presented one of the slide, and then have a good life and suddenly deteriorating and go to the acute ward in the hospital, then go to this ICU and stay for a period and then die. And then people, they go and then come back to home and go again to the hospital, then come back, and then they lose their certain extent of the activity power, and then again they go back to with this acute exacerbation and like that. So then particularly this cancer and things, and you know that people gradually they die, particularly this part of the world, that because we detect cancers in a late stage. So then the problem is here, not only the patients, but also all the family members, that we are not ready to prepare and then think and then plan for our death. So that's make a lot of problems, particularly that's create a lot of problems for the patient, family, and also this community, and also the hospitals. So you need to see that when we go to our emergency departments, around 30 to 40% of the patients, they are like palliative care patients, they come to the emergency department, then they compete with the real emergency patients. So then with already we are running with the shortage of the physicians and the nurses. So these competing patients are coming to that patients that particularly they are in the end of life care, the patients, those who need, they come to the emergency ward because parents, these relatives and the family members are very scared about that. Now that when patient is on pain, or maybe then having a difficulty of breathing, or then sometimes the patient is not going, cannot take orally, and those then that make these family members very anxious, and they bring that patient to the emergency department, and then the emergency department, then they transfer that to the inward facilities, and in a day or two, then they ask these family members, no, 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 we can't do this, hospital can't do anything, that we better take the patient back to home. So as Madhurahan said, that some of the patients are coming from very far away without proper transport facilities, and then uh, uh, they have to spend a lot. But after coming here, again, then they have to take back this patient to home. There's no any place to keep them. So they, again, after a few days, then they are forced to take the patient back to the hospital. So there are other patients really, and they have to, they really, actually, for me to actually, that forced me to think about this, the palliative is very important, because in the health, our health system, most of the health system managers, they said, we have very good coverage of the hospital, so we have primary care network, so then we don't need this kind of home care and things. But when I was doing my research in cancer things, that was my doctoral research. So what I found then, when I was visiting to these cancer patients, most of the patients in rural villages, as Madhagan showed, there are so many rural villages when we have a difficulty of access of roads and things. So they are there with all the pain, and particularly when they develop these metastases, bone, lungs, brain, and all these places, and they have pain and all these things. But they, with that pain, suffering, and they are at home, and nobody is there to take them to the nearest hospital to provide the pain. Even they are taken to the hospital, most of the hospitals are not providing enough medication, particularly this for the chronic pain. So most of our health professionals, even the doctors, nurses, are not trained in chronic pain management. So acute pain management and the chronic pain management are totally different. Most of this, until even I, actually this enlightening, I got that opportunity. I was listening, one of the leading palliative care expert, Dr. Suresh Kumar, I'm very fortunate with the support of KN UK. I was sent to the, Kerala to get this palliative care training. So I was working with him. So he came with his colleagues to Jaffna in the Jaffna Medical Association, one of the session in 2013. Then only I got to know this. There are a lot of stuff to learn about palliative care. So this, most of these medical undergraduate or postgraduate education, even physicians, general physicians, are not getting enough insight about palliative care. So particularly, what is thing that palliative care, again, Jonathan mentioned that particularly people develop chronic disease. Chronic disease is a kind of a progressive, long-term diseases like diabetes, heart diseases like high pressure, cerebral vascular disease, cancer, chronic obstructive pulmonary disease. All these diseases, these are not developing long period. So we try to prevent them most of the time. But unfortunately, in our country, the prevention part also, we are still struggling to formulate a very good program. And also this public also, they are not worrying about that. So then we detect somewhere after developing something, even this with the complications. Sometimes that we detect diabetic patients after developing peripheral vascular disease. So with this nerve pain and leg pain, some of the people come to with diabetic wound, then only we diagnose them as with the diabetic. So that when we diagnose them, so most of the time our care service, the present context, most of us know what is that? That a curative and life prolonging care. But actually with that, when these people develop symptoms, that's what this concept that as indicated in the other presentation, is the lady brought this concept of hospice care, and then the WHO 2002 defined that clearly what is palliative care. So the palliative care is a kind of life actually to improve this, providing the quality of life of the patient and ensure the patient to have a meaningful life, not only the patient, but also with the family members. So that kind of comprehensive care, so it is a really new concept for Sri Lanka. So India, of course, then they, even though their coverage is very low, as Dr. Gayatri Palliative said, but they started a very long history. Even this Kerala, these pioneers, Professor, I hope it is Dr. Suresh Kumar and the professor, the two palliative care leaders in the Kerala, they started this palliative care concept and they developed in mid of 80s. But in Sri Lanka, we started to talk about in after 2010, 2011. So then the even group of GPs in Colombo, then their GP association, they have some collaboration with the Kerala, and then they started to talk about this palliative care. Even Sri Lankan Palliative Care Association formed in 2014. So again, exactly that palliative care policy of the Sri Lankan one is launched in 2019. You see that now only the things are picking up, but that fortunately the northern province, with the support of various organizations, particularly NGOs, and then the administrators, particularly Dr. K. Viswaran and other people, because of that, we could able to move and establish new kind of setup, and also then home care services as indicated by Madhuragan. But this is a good opportunity as well that Dr. Varagunan created this. So I hope that beyond this audience that it has to go out. So now it's a time, because we were also a little bit reluctant. We were waiting for 3 years to come up this kind of discussions, because still we don't have enough resources. So we are running these services with the limited resources. Only 2 doctors and 2 nurses at the nurses and other few nurses in the train so far, and then a few health professionals. Dr. Kavita is an oncologist, also trained, and then me, and we had 2 specialist physicians trained in palliative care. One person after a few years and he left to Australia, and unfortunately Dr. Raghupati is a physician, as Meera mentioned. So he was really helping us to set up this palliative care. Unfortunately, untimely demise of his also then made us to in the progress of developing palliative care. So when you look at this palliative care thing, then came organization really that they wanted to start this. They were running the home-based palliative care. When we go back to their previous history, and then that is available in the Kane Facebook, and also this Dr. Kamala is one of the audience here. So then they really started this after looking at these palliative care services in UK. So see, they brought up this concept to Northern Province. So then that concept really after started to provide home care, and they thought that there is a need for the hospice, because there are a lot of people they need support during their last stage, because there are a lot of people without their relatives and other support. So then they tried to develop a hospice. So then so first hospice actually, that the picture that you can see, the 20 beds open hospice, so the for the males and the females, built in Univille. So that is a hospice still functioning with the same, then recently that are renovated, but the hospice still we are running. It's not a fully fledged hospice, because we don't have 24 hours medical officers to provide services, and also we don't have qualified nurses to run this hospice. But we are running this with part-time visiting doctors and the nurse, one qualified nurse, and then few other healthcare assistants. Particularly these, we are actually providing services to patients coming far away, and then they are undergoing treatment in Telepala Hospital, and they are provided all the food and other supportive care while they are in Jaffna. And also we get patients that those who really there's nobody at home to look after, and they come and also stay at the hospice and die. So then that kind of facilities is available. So then after that, we tried several times to develop these hospital-based palliative care clinics. Actually, base hospital Telepalai, and then I forgot to write it as a Baunia hospital, and then the teaching hospital Jaffna. There are outpatient clinics started in 2012 and the 2015. As I mentioned, there are one OMF surgeon in Vonia, then Dr. Ranjan Malavaraj. He started this association, Northern Palliative Care Association, and then he started a clinic at the Vonia General Hospital, and also then he was doing home care and trying to develop some of the part of the Setikulam Hospital as a hospice place. But unfortunately, he actually got transferred to the Puliyapitia. After that service also we couldn't continue. Then what happened with these, Dr. Pradhivan was running the clinics in Kalipalai and Jaffna Teaching Hospital, and he decided to move to Australia, and also we were not able to. Then Dr. Raghupati came back from India, England, and then he was helping us to run this. Unfortunately, unexpectedly, he also died. So then we were really struggling that to continue this. So then actually this initiative, Two World Cancer Collaboration, I am not expanding more, but already that is clearly that mentioned by Meera. This Two World Cancer Collaboration initiative actually help us to continue the sustainable palliative care services, at least in 2 districts, one in this base hospital Telepalai and another one in the hospital Vonia. So this hospital outpatient clinic, these doctors are not, they are actually, Madhuragan is attached to cardiology unit, and Housingen is attached to the oncology unit, but they are actually doing in addition to their routine work. So this is their palliative, doing as a palliative care, working palliative medical is their additional job. So then they are conducting these palliative clinics, whatever this referral work come to them in the hospital. Then after working hours, they go to the field with the nursing officers, and we are offering these home care services. So at the moment, we are not covering that. Some of the discussions were going on that about our coverage of the care. So that coverage still that we are trying to maximize our coverage. Most of the needed palliative care needed oncology cases we are trying to address. So when we are looking at these, whether it's a cancer patient, most of the cancer patients, we try our best to attach. But that, as Gayatri said, in the even WHO clearly indicated, the more palliative care services are needed for the cardiovascular, heart failure, peripheral vascular disease, and then the stroke, and then chronic kidney diseases, renal failure, and the respiratory failure, liver failure. All these patients are not getting real support. So then the need is immense. So then we don't know then. So now we are actually covering with the limited resources. And also now that there are initiatives to expand, and then the other districts. So with the support of Provincial Health Director Dr. Keviswan is here, and then we try to find out at least a couple of medical officers and nurses, and there are a few other organizations in addition to IMHO, Canada, and UK, Two World Cancer Collaboration, and there's this Australian Medical Aid Foundation also showed the interest to help us in this journey. But unfortunately, this COVID-19 came, and we are not able to send these medical officers to Gayatri's place to get the training. So now we are actually have a discussion and planning, particularly that we are going to get the support of Gayatri and Two World Cancer Collaboration. We want to do some online teaching and the training program with the help of this home care team and the discussion. So we are thinking to start some training program maybe in next month to medical officers and the nurses who are identified from Kilnochi, Mullaitivu, and Mannar. So that is the way that we are expanding our services. So when you look at this national level, this is the concept that I'm sharing with you that is mentioned in our this policy, palliative care. So then they have actually that, as Gayatri said, the most of these palliative care patients care, it should be really correlated with the primary care. So in Sri Lanka, now that with the support of the World Bank, there is a primary care strengthening program is going on. So through that program, they have identified recap palliation as one of the components. So that should be able to provide it through the primary care. So then there are hospitals, primary care hospitals, regional hospitals, not utilized for the acute care, could be utilized, and those beds can be allocated for the palliative care patients. But most of the patients here in Sri Lanka, they want to die at home. They don't want to go to the hospital and die. So then very important is to provide the home care. So the home care, now that ministry started to train public health nurses and the nursing professionals to provide the home care. So then also we need to train the volunteers. The role of the volunteers really very useful, and that particularly that we learned that from India. So India success in the Kerala and then the Telangana and all these places, that is role of the volunteers. So the volunteers, community groups, and then the public health system all should help us to run. That is the expectation. And then patients can be referred to the general hospitals. Actually, that cancer control program, Sri Lanka, it's a focal point for the palliative care. They have identified medical officers cadres to main hospitals in Sri Lanka. But then these cadres still not approved by the Treasury, the cadre commission. So they are waiting this time to approve. So once they approve, then there will be a designated medical officers will be available at in these hospitals, maybe in a year or two. So when these people are available, then they can run the clinics at the hospital. So the clinics may be the place where that all the patients can be referred, and then from that base, that patients could be referred to the home base, and then home-based palliative care could be operated from there. So that is the aim, but it's still that Sri Lanka, these palliative care initiatives are in primitive level. So we don't, this Ministry of Health doesn't have any cadre position actually designated to palliative care. But the education, training of medical officers, at the moment there are 2 batches of diploma in palliative care. Medical officers trained in diploma are graduated. So then, but still that we are looking for the cadre positions. But that we don't have any palliative care expertise at the moment. There are discussions that where to start and how to start, but that we have to wait another 5 to 10 years to get the palliative care experts to this country. But that we can't wait, that we know the problems, and we understood, and all of you understood these issues. So then it is our duty to train most of these medical officers and the nurses, physiotherapists, occupational therapists, and we need a lot of counselors. So even this counseling is a big problem. We don't have counselors, trained proper counselors in the Department of Health. So there's counseling. So we need a lot of social support, social organizations. So that kind of thing, and as a community movement, that way that we can help. And then again, the hospice care, actually there are a lot of elders now that their children and family members are either died or migrated, and they need a lot of support. So there are people who can afford, and they are getting paid places, but there are people that they can't afford. So they need a very good support, particularly daily. Then their food, symptom management, and all these kind of care that could be only offered by the hospice. But that at the moment the renewal is trying to provide, but that we need a very comprehensive, good hospice. And there are initiatives to develop that also, that we need support to develop that hospice. A place is identified near to Navarkuli, but that we need a lot of money and other support to develop that. So with this remark, so right, but with this quote that I want to finish my presentation, and thank you very much for the opportunity. And also that's it's like it's a wonderful team effort. The team effort is all over the world and here local. So I'm very proud to work in this team. Thank you very much.
Thank you very much, Dr. Surendran. You are always there for the patients and you're always there for the team. Just a little explanation before we have a very short presentation from it's a case presentation, going to be interesting. As IMHO Canada president and, representing many of these NGOs, or you call the international charity organization, our job is not to replace what the government is doing. We are here to bridge the government and the services, but eventually I'm very positive, and we have Dr. K.D. Swaran here who is going to give a concluding remarks. Eventually the government will take over, and we are talking with 3 other organizations now to expand this services to the other districts. One is the Australian Medical Aid Foundation. The other one is the IMHO USA, our sister organization. And of course, I'm talking with our Canadian Tamil Medical Association. It's all in the preliminary stages, but we are very positive we'll come to a very big announcement in very shortly. Thanks again, Dr. Surendran. You can stop sharing your screen.